Hello, I'm Dr. David Stewart, and today I'm going to talk about toe walking in children using an evidence-based medicine approach. This involves a systematic citation of pertinent available research, evaluation of research quality, and acknowledgement of knowledge gaps, limitations, and controversies. Evidence-based medicine has moved away from expert opinion, which has been shown to vary widely and to have limited reliability. Evaluation of evidence takes more effort, but it can help patients and providers make better, more informed decisions. Toe walking is often a normal developmental variant in toddlers. This developmental toe walking usually resolves by 2 years of age. Toe walking that persists beyond that time, which is not associated with neurological or orthopedic conditions, is called idiopathic toe walking, or ITW. Idiopathic is a medical term that means the doctors do not know precisely why it occurs. Children over the age of 2 years who walk on their toes may benefit from medical evaluation for diagnosis of potentially associated conditions and for discussion of treatment options. Some younger children may also warrant evaluation, especially if contractures, excessive tone, unequal tightness, or other medical conditions are present. Toe walkers manifest varying patterns, from children who stand, walk, and run on their toes to children who do only some of these. Toe walking can be constant or intermittent. Idiopathic toe walking can improve with time in some children, but persists in others. A 2022 review of idiopathic toe walking in children found only one prospective natural history study. Of children with ITW without contractures, 59% resolved by age 5.5 years and 79% by age 10 years. In 2000, Eastwood and colleagues in Australia published the largest series of children with idiopathic toe walking at that time, with 136 patients. At an average age of 3.2 years of follow-up, only 6% of patients who received no treatment reported achieving normal gait. 45% reported partial improvement, and 49% reported no change. Toe walking may be less likely to improve spontaneously in children with neurologic or neurobehavioral conditions. Referencing data from 2005 to 2016 in a national insurance database, Leiden and colleagues at Stanford reported that 63.6% of children with autism spectrum disorder who did not undergo medical treatment continued to walk on their toes within 10 years, compared to 19.3% of children without autism. Evaluating why a child walks on his or her toes is important to diagnosis and treatment. Some children with ITW may walk on their toes out of habit, or perhaps because toe walking feels normal to them. Idiopathic toe walking without contractures typically does not result from any structural abnormality in the lower leg, foot, or ankle, but rather arises from excessive stimulation of the gastrocnemius and soleus muscles by nerves transmitting signals from the brain and spinal cord. ITW is a diagnosis of exclusion, meaning that it is confirmed only when other possible causes have been evaluated and ruled out. Sometimes idiopathic toe walking may run in families. Motor planning challenges and sensory processing differences have been cited as potential factors in idiopathic toe walking, although research findings have been inconsistent. Evaluation by a neurologist or neuropsychologist may be recommended if findings are present that may suggest an underlying condition, or if toe walking is not improving in an otherwise healthy child. Contracture of the Achilles tendon can develop over time in some children when the ankle persists in plantar flexion. This may occur because of habitual toe walking or because of excessive tone in the gastrocnemius and soleus muscles due to a neurological condition. Asymmetric ankle tightness, with one side notably tighter than the other, in the absence of a known orthopedic cause may raise concern for an underlying neurological condition. Children with Achilles tendon contractures who cannot reach a neutral position of ankle dorsiflexion are called obligate toe walkers. This means that they cannot bring their heel down due to a mechanical block. For these children, treatment needs to address the contracture, whether through stretching or surgery. While an Achilles tendon or ankle contracture may not be the only reason a child walks on his or her toes, achieving 10 to 15 degrees of ankle dorsiflexion is necessary for a normal gait. This is because the body's center of gravity passes over the ankle in the stance phase of gait and requires some ankle dorsiflexion to achieve a normal stride length. Children with normal ankle range of motion who toe walk do so for some reason other than a fixed contracture. This is referred to as dynamic toe walking because it occurs as a result of excessive muscle contraction. Children with dynamic toe walking are able to stand flat-footed and are less likely to benefit from surgical tendon lengthening. Tendon lengthening is not a reliable solution for toe walking when the cause is not that the tendon is too tight, but that the muscle is being overstimulated. Out-toeing can also predispose to Achilles tendon tightness and toe walking for mechanical reasons, which will be discussed in another video. A study conducted by Haynes and colleagues in Dallas reported that 62%, or 108 of 174 patients referred by orthopedic surgeons to neurology, were diagnosed with an underlying neurological condition. 37% had previously undiagnosed cerebral palsy. 16.7% were diagnosed with peripheral neuropathy, 15.7% with autism spectrum disorder, 13.9% with hereditary spastic paraparesis, 8.3% with attention deficit hyperactivity disorder, 5.6% with a syndromic diagnosis, and 2.8% with a spinal cord abnormality. This does not mean that 62% of children who walk on their toes have a neurological diagnosis. Orthopedists typically refer patients to a neurologist only when they have clinical suspicion of a neurological condition, and so this group represents only a subset of toe walking children. Whereas Achilles tendon contractures can occur in children with both idiopathic and neurologic causes, one-sided toe walking or asymmetric tightness can raise concerns for neurological etiology. Haynes reported that of children referred to a neurology clinic by an orthopedist, 71% of children who toe walked on only one side and 32% of children with asymmetric toe walking were diagnosed with cerebral palsy. Toe walking is common among children with cerebral palsy, an injury to the brain that occurs at or around the time of birth. Blood vessels in the brain are fragile in infants, and especially in premature babies who have an increased risk for intraventricular hemorrhage or stroke that can lead to cerebral palsy. The nerves that control the lower leg muscles, including the ankle flexors, are particularly susceptible to injuries resulting from bleeding or ischemia, the lack of circulation to the infant brain. This is due to their location in the parietal lobe near the central sulcus and lateral ventricles of the brain. These are called watershed areas or border regions of the brain with limited blood supply, which are more vulnerable to decreases in circulation. Their location is shown on what is called a cortical motor homunculus, which depicts body parts controlled by different regions of the parietal lobe of the brain. Cerebral palsy is typically diagnosed by a neurologist. While certain findings on a brain MRI or CT scan may demonstrate evidence of cerebral palsy, normal imaging studies do not necessarily rule it out. This is because nerve injury or dysfunction can occur in the absence of major anatomic disruption. At times, gait analysis studies, including electromyogram and multi-segment foot model, may help to diagnose mild forms of cerebral palsy. A neuropsychologist or neurobehavioral specialist can assess for autism spectrum disorder, Asperger's syndrome, attention deficit hyperactivity disorder, or ADHD, and other conditions. Layden and colleagues at Stanford University found that of patients in the National Insurance Database from 2005 to 2016 with autism spectrum disorder, 8.4% or 484 out of over 5,700 were diagnosed with toe walking. A study from Virginia Commonwealth University, published in 2011, reported on toe walking children seen by a developmental pediatrician for initial evaluation. There were 954 patients, and among children with autism, which was 324, 20.1% had persistent toe walking and 12% had a tight Achilles tendon. Among children with Asperger's syndrome, 10% had persistent toe walking and 3% had Achilles tendon tightness. A systematic review of studies published between 1966 and 2013 of idiopathic toe walking in children between 2 and 18 years of age found only one randomized controlled trial and 18 observational studies. In 2012, Dr. Frederick Dietz summed up the state of knowledge regarding idiopathic toe walking, writing, "The natural history and optimal treatment for idiopathic toe walking are unknown. The literature is full of poorly documented treatment regimens with few, even medium-term follow-up studies." Some limitations of published medical research on idiopathic toe walking include the following: primarily retrospective studies with less robust levels of evidence, or LOEs, than prospective research, small numbers of patients, lack of range of motion measurements and other outcome measurements in some studies, different methodologies and data points that make comparisons difficult, and inconsistencies of definitions and nomenclature. Nomenclature and definition inconsistencies include the designation of patients with some neurobehavioral conditions as idiopathic in some literature. Toe walking associated with a neurobehavioral condition cannot be idiopathic, which means that no underlying diagnosis is present. The lumping of neurobehavioral toe walking with true idiopathic toe walking in some research studies may confound results and makes them difficult to interpret, as the two have been shown to have different natural histories and responses to treatment. Subsequent studies have provided additional insights and clarification, yet the quality of research findings for treatment of idiopathic toe walking remains very limited, and controversies persist. The nature and role of treatment for idiopathic toe walking is controversial. Some common treatments include observation, cueing, stretching, casting, bracing, and surgery. A pediatric orthopedist can evaluate your child, listen to your goals and expectations, and discuss options and recommendations. Non-surgical options include observation, cueing, stretching, serocasting, and bracing. Surgical treatment lengthens the Achilles tendon or gastrocnemius muscle. Some children may not require treatment for toe walking. If a child has normal or near normal range of motion at the ankle and is not experiencing pain or limitations, monitoring the condition without intervention may be reasonable. Sometimes toe walking may improve in time, although it may also persist. The child's functional status and the family's desires and expectations are important in deciding whether to pursue active treatment. Cueing refers to the use of a word or phrase to remind a child without contractures who habitually toe walks to come down off his or her toes to a normal heel-toe gait. Some children are able to walk normally when reminded, but may return to toe walking soon after. This may occur in any child, but is particularly common in children with ADHD, autism, or other neurobehavioral conditions. These conditions may limit the ability to maintain focus. Stretching can be helpful to improve ankle range of motion to facilitate a heel-toe gait. Stretching exercises may be done as a home exercise program with or without the assistance of a physical therapist. Exercises can be helpful in stretching the Achilles tendon. An incline or slant board can also be useful. Several inexpensive commercial slant boards are available, or one may be improvised from material in the home. Stretching exercises are most helpful for toe walking children with mild Achilles tendon tightness. Published medical studies have shown little success in correcting large Achilles tendon contractures in toe walking children with exercises alone. Stretching casts have sometimes been used to stretch mild to moderate contractures. The protocol typically involves gentle stretching of the Achilles tendon with cast changes at 1 to 2 week intervals. Casting may continue for 4 to 6 weeks, depending on the contracture severity and rate of progress. Caution is required with stretching casts, as stretching casts rely on the cast to achieve and hold a position beyond the child's normal range of motion. There is an increased risk of pressure sores. This is especially the case in children with neurological or neurobehavioral conditions who may have altered sensation and/or diminished ability to perceive and express pain. The medical literature has shown little evidence of sustained efficacy from casting for toe walking. A systematic review of toe walking studies by Van Kuijk and colleagues in the Netherlands cited evidence of some improvement in gait with serial casting, but noted that normalization does not occur and that casting did not lead to sustained improvement beyond 1 year. The Australian study by Eastwood and colleagues found that casting had similar outcomes to no treatment. They reported that cast treatment did not alter the natural history. A 2012 literature review of 10 studies by Van Bemmel and colleagues reported a minimal 3.1 degree improvement in ankle dorsiflexion with casting 3 years after treatment, but without evidence of functional difference. The use of Botox or botulinum toxin A injections as an adjunct to stretching casts is controversial. The literature review study by Van Kuijk found no benefit to Botox with casting. A randomized study of 47 children with idiopathic toe walking conducted in Sweden by Engström and colleagues also found no benefit to augmenting cast treatment with botulinum toxin A or Botox. An Italian clinic treated 22 children with toe walking and autism spectrum disorder with Botox and casting, and they reported short-term improvement. However, there was no long-term follow-up and no control group of casting without Botox. And so the results are difficult to interpret. Because of the lack of evidence for benefit of casting and because of the risk of pain and pressure sores and the need for multiple casting sessions, minimally invasive techniques for lengthening the Achilles or gastrocnemius tendons may offer improved risk-benefit profiles for some patients with contractures. Bracing with an ankle-foot orthosis or similar orthotic has been shown to reduce toe walking when children are in the brace. However, patient numbers have been small and follow-up limited. Some studies have reported that children may tend to revert to toe walking when bracing is discontinued. Optimally, a brace should prevent or discourage excess plantar flexion at the ankle, while still allowing ankle dorsiflexion to strengthen the respective muscles. Bracing can only be used for toe walking when the ankle is able to reach neutral or near neutral dorsiflexion. This is because a brace placed on a contracted ankle is an accommodative brace which merely holds the ankle in its contracted position rather than achieving heel strike. Occasionally, a small heel wedge may be placed if there is a minor contracture of only a few degrees. However, patients with larger contractures are usually not good candidates for bracing and are more likely to benefit from surgery to achieve a plantigrade ankle. Daytime bracing in children with mild to moderate Achilles tendon tightness can improve gait while worn and keep the ankle stretched out. The rule for nighttime stretching brace in toe walking is unclear. Daytime braces help children when they're actually walking, and because most children need a break from bracing at night, in some cases, bracing may be helpful after surgery, especially in the case when ankle dorsiflexors are weak or when ankle contracture coexists with habitual toe walking. A study reporting on 204 children between the age of 4 and 7 years of diagnosis of idiopathic toe walking treated between 2008 and 2015 reported that only 59% of children, or 121 out of 204, attended at least one follow-up visit. Among those who followed up, just 45.5% had a successful outcome with improved gait. Among various treatment modalities, only bracing with AFOs or ankle foot orthosis was statistically associated with improved short-term outcome with unadjusted and adjusted odds ratios of 3.97 and 4.81 respectively. One study reported meaningful improvement with a circular subtalar blocking orthosis in 2/3 of patients, although the study was retrospective with only 22 patients and follow-up was limited to 2 years. Surgical lengthening of the gastrocnemius or Achilles tendon can result in improved ankle dorsiflexion, although this does not always correlate with the resolution of toe walking. The systematic review by Van Kuik noted improved gait with surgery, which was sustained beyond 1 year, but not full normalization. A systematic review by Van Bommel and colleagues reported a 14.2 degree improvement in ankle dorsiflexion 3 years after surgery, but cautioned that they were unable to draw definitive conclusions regarding functional improvement due to methodological limitations of published studies. Some of the medical research is confounded by a lack of clear differentiation between children with contractures of the Achilles tendon and those without. In the Australian study by Eastwood, among patients who underwent Achilles lengthening for toe walking, 22% reported normal gait, 50% reported partial improvement, and 26% reported no change, 2% reported actual worsening. Surgery had very limited benefit, with only 16% more patients, or approximately 1 in 6 in the surgical group, reporting normal gait compared to those without treatment. No pre- and post-operative range of motion figures were reported in their study, however. The limited benefit may relate to patient selection issues, including operating on patients without significant contractures in some studies. Surgery can benefit selected patients with toe walking due to ankle contractures, but has been shown to have little, if any, benefit for idiopathic toe walkers without contracture. Today, We've covered information regarding the condition, the causes, the natural history, and the treatment options for toe walking in children. We've also reviewed some of the key medical research regarding each item. If you have any questions or comments, please write to us in the comment section below or at our website, pedsortho.com. Thank you for watching. Have a great day.